All right, good afternoon, everyone, and welcome back to some of you, and welcome to some others of you. My name is Dr. Lucy Ingram, and I am faculty at the University of South Carolina and also co-leader of the research education component of the Carolina Center for Alzheimer's Disease and Minority Research. We are so pleased to have had such a great morning, very informative speakers, and our next session is no exception. So we'd like to remind you all to please put in the Q&A feature, type if you have a question for our panelists. We will hold all of our questions until the end of each session. And if you have any pleasantries that you'd like to say amongst yourselves, you can use the chat feature for that function. So without further ado, I will introduce our speakers for our next session, and these will be Mrs. Jo Pauling Jones, Dr. Lisa McGuire, and Ms. Taylor Wilson. Mrs. Jo Pauling Jones is the Associate State Director of Advocacy and Outreach at AARP South Carolina. She has more than 36 years of executive leadership, community engagement, advocacy, and outreach experience. Her work focuses on disrupting health disparities, caregiving, fraud prevention, and multicultural outreach. Dr. Lisa McGuire is the lead of the Alzheimer's Disease and Healthy Aging Program at the Centers for Disease Control and Prevention within the Department of Health and Human Services. She is a member of the National Alzheimer's Project Act, Federal Advisory Council, and Board of Directors for the National Alliance for Caregiving. Ms. Taylor Wilson is the current Director of Government Affairs at the Alzheimer's Association South Carolina chapter. She was also Director of Communication and Advocacy and Director of State Policy in 2019 at the Alzheimer's Association South Carolina chapter. Our speakers will now lead our fourth session entitled How Alzheimer's Disease Data, including Registries, Guide State and National Initiatives. Jo, take it away.
Thank you, Lucy. Let me share my screen. All right, I believe we're ready to go. Again, I want to thank you, Lucy, for inviting AARP South Carolina to take part in today's panel discussion. We appreciate the opportunity to be here and share information in regards to how we are using the Alzheimer's Disease Registry to guide state initiatives. As we look at the mission of AARP, it is to empower people to choose how they live as they age. We recognize that there are many factors that impact the ability of all of us to choose how we live as we age, many of which have been talked about this morning during this morning's sessions, and we will carry that over into the afternoon because it's very related. Financial resilience, social health, access to care, lifestyle, and education. At the national level, there's a major focus on ensuring that longevity and people living their best lives is attainable for all. One of our founder, Ethel Percy Andrews' favorite and most popular quotes is, "What we do for all." And AARP abides by that philosophy. Our Disrupting Disparities initiative is designed to collect data and recommend policy prescriptions on disparities within the 50+ community. Starting with AARP New York in 2018, multiple state offices have collaborated with local partners to collect data on health disparities related to race, ethnicity, gender, and sexuality. In 2020, AARP South Carolina began to connect our work, our state work, to the national initiative. Our partnership with the Arnold School of Public Health and the Alzheimer's Disease Registry began to take shape. This was our first tangible benefit and our ability to partner to inform our research. After our initial review of organizations conducting research for older South Carolinians. We funded a phase 1 quantitative research project with the South Carolina Aging Research Network under the leadership of Dr. Heather Boger at MUSC, Dr. Cheryl Dye at Clemson, and Lucy Ingram with USC. The lead researcher for the phase 1 quantitative research was Dr. Cheryl Dye, who you will hear from in our next session, along with her graduate student, Kelsey Vinson from Clemson University. We went into the research with the understanding that South Carolina non-Hispanic Black people over the age of 50 years old suffer multiple socioeconomic and health disparities compared to their white counterparts. You've heard that before many times, and again this morning, and now we're repeating it this afternoon. We decided to focus on the 50+ African Americans here in South Carolina because of their disproportionate numbers and the impact on that population. After completing the phase 1 research, we understood the importance of giving voice to individuals here in South Carolina who were directly impacted by health disparities. And you heard Dr. Rowland speak to that this morning. Dr. Lucy Ingram was the lead researcher, with Cheryl Dye being a consultant, and Dr. Heather Boger also lending consultation to the phase 2 research. Under Dr. Ingram's leadership, the phase 2 research focused on understanding the contributors of health disparities, community perceptions, and potential strategies to address health disparities. Phase 2 conducted 45-minute interviews with 47 individuals along the corridor of economic disadvantage here in South Carolina. And those responses that we received will inform the future direction that we take. When we look at the benefits of our partnership with Dr. Ingram, Dr. Dye, and Dr. Boger, it did not end with the research. As we move forward, we are working on additional collaborations, which was one of the phase 2 research recommendations. AARP South Carolina has formed a health disparities strategy team made up of lead volunteers with expertise in health disparities. We are exploring the potential of hosting a collaborative meeting with individuals and organizations who have spent years working on health disparities. We want to be at the table to represent the 50+ voice with the understanding and the respect for those who have been at the table before us. So going forward, we will promote the Alzheimer's Disease Registry as a valuable data source as we continue to think through and strategize on those connections across the work and how we partner at the local level. And finally, I'm excited because with the help from this research team, and the information that we will be able to draw from the registry, we will unify a lot of the work that we're doing at the AARP state office when it comes to our priority areas. And those priority areas are health disparities, livable communities, caregiving, brain health, veterans affairs, among many others. And so we're excited to be in this position where we can continue to work with the registry to pull data that will be valuable in helping to inform how we move forward in this work. If you want to learn more about the health disparities research that we conducted and obtain a copy of the full reports, please visit aarp.org/South Carolina. It's listed here. And then the other link that I want to share with you is in regards to our livable communities work, because one of the things that we, as a result of the research, we've already begun to work more collaboratively internally with our livable communities and health disparities work. And as we continue to look externally at how we can do this work, we will definitely be taking that model and bringing it forward. And then if you want to stay informed on all of the work that AARP is doing, please visit aarp.org. And lastly, if you or anyone you know is interested in volunteering with AARP as we continue this work, please reach out to me. We would love to have you join us as we continue to improve the work that we're doing on behalf of the 50+ population. Thank you.
Fantastic. Thank you so much, Joe. Dr. McGuire, whenever you're ready to share your screen.
All right, so people can see my slides?
Yes.
Okay, great. I have learned to ask that question the hard way. So good afternoon, and thank you very much for the invitation. I, as well as I think many others at CDC, really value and love data, and we recognize the amazing stories that can be told with data. And hopefully today I'm going to share some of the things that we are thinking about at CDC and also at the national level. So this is the lay of the land for our perspective at CDC. And a couple things that I want to point out to you is a couple things that have occurred recently that really matter. So the first thing I'm going to point out to you is it wasn't until 2009 that on CDC's behavioral risk factor surveillance system did we start adding questions related to caregiving and cognitive decline to that survey. It wasn't until 2010 for Healthy People 2020 that we were able to get questions or get information or objectives about dementia on and included as Healthy People objectives. Just kind of some other evolutions that we see is building our largest dementia infrastructure, which was signed into law in very late 2018. But the third component of BOLD talks about timely analysis and reporting of data as it relates to persons with dementia, cognitive decline, and also caregiving. And so I'm going to go on and talk a little bit more about some of the things that we're doing at CDC and how they intersect with those activities. So one of the logos that you've seen on my slides is the Healthy Brain Initiative. And what that Healthy Brain Initiative is, we are working to really try to integrate brain health, and I mean that as broadly as you can conceptualize it, keeping brains healthy for people who are experiencing cognitive decline, such as dementia, and support for their caregivers. We're trying to get that integrated within public health strategies. And one of the biggest activities that we do with the Healthy Brain Initiative is to develop our roadmaps. And what our roadmaps do, and you can see the progression of them over time. So the very nice African-American lady here in the larger graphic, this is our third in the series of the Healthy Brain Initiative roadmaps. So what these maps do is they identify national objectives for state and local public health based on the current science, what we know that's going on within public health, in a whole variety of different different reasons. And we identify priority areas. So the most current roadmap has 25 actions that are fit consistently with the essential services of public health, 4 of the 10 essential services of public health. So here is that wheel again with 4 of those 10 essential services of public health. But here are some of the major categories that we find that are the most important included in this wheel. So first, we want to ensure that we have a competent workforce. And that, once again, is met broadly. That is from providers, that could be physicians, nurses, nurse practitioners, occupational therapists, CNAs. That can be as broad as you can think about it, making sure that the workforce is competent and prepared to address people that are that are coming to their provider and saying they're having a cognitive decline, or people who are caregivers, and really making sure that the workforce is prepared and equipped for that. The component that's most relevant to us today is the monitor and evaluate. So that's where the data pieces come into play. So this is where we're talking about not only collecting data, but as Joe mentioned as well, taking that data and utilizing that data for action. And you can see that sometimes when we are utilizing that data for action, we're into that third quadrant, which is developing policies, mobilizing partnerships. And then the fourth characteristic or quality is educating and empowering our communities. So in other words, those educational campaigns that my colleagues at ARP and the Alzheimer's Association do such an amazing job at. But we are, once again, many of those are data informed. So I'm going to talk a little bit more about some of the Healthy Brain Initiative activities, and we'll get to the data in just a second. When we developed our third roadmap, we were concerned that we were not seeing uptake in our roadmap actions in tribal communities and tribal organizations. So in 2019, we launched the Healthy Brain Initiative roadmap for Indian country. It is a little slightly different, but as you can see, if you look at these general categories of the roadmap strategies, they fit fairly nicely with those essential services of public health. So once again, educating and empowering community members, collecting and using data. And that really the key is the using that data. And then the third component is strengthening that workforce. So once again, as broadly as we can possibly think of that. So I showed you on my graphic in 2010, when we were able to get dementia objectives included in Healthy People 2020. Well, the mantra I will say for Healthy People 2030 was reduce, reduce, reduce. But as we know, Alzheimer's disease and related dementia is an important public health crisis in our nation. And we were able to make a very strong case to actually add another objective to Healthy People 2030. So I know it doesn't sound like that big of a deal, but hundreds upon hundreds of objectives were cut. So we were very pleased because we had to go in front of committees and provide our justification to keep our objectives 1 and 2. But then we had to have a really, really good reason why we wanted to add this third objective. And so with that third objective, what we wanted to see was we wanted to see people who say, my cognition's not quite what it has been, and it's getting worse over the past year. We were wanting to increase the number of people who are going to talk with a healthcare provider. So you can see it kind of fits back into those essential services of public health. We know that only about 50% of people who say my memory's getting worse have actually talked with a healthcare provider. So we not only want to empower people and educate people on the reasons why they should talk with their healthcare provider, but we also need to make sure that our workforce, our providers are prepared to have those conversations that either might be dementia screening or possibly even could be just talking about risk factors and risk reduction or looking for other complicating or treatable symptoms that might be resulting in a delirium as opposed to a dementia. So I think just there in that one illustration about why DIA number 3 is so darn important, I think we're seeing many of the different quadrants of those essential services of public health from our roadmap wheel, as we lovingly refer to it. So one of the other logos you've seen on my slides is bold, and I highlighted bold at very beginning of my yellow brick road discussion of our trajectory. So these are the full 3 components of bold. So bold was signed into law in late 2018 and then did receive congressional appropriations in the next fiscal year to start some funding. So the bold legislation charges CDC with developing public health centers of excellence. We have funded 3 of those. The first is on early assessment and diagnosis, and that is funded at NYU. The second is on dementia risk reduction, which is funded to the Alzheimer's Association. And the third Center of Excellence is on dementia caregiving, and that's funded to the University of Minnesota. Through that funding, we also, with the second component of BOLD, is we provide funding to public health departments across the nation. The whole real intent of BOLD is to strengthen the public health infrastructure related to dementia and dementia caregiving. So CDC is charged with funding these public health departments, and in the legislation, it says they must be states, political subdivisions of states, tribes, or tribal organizations. So we do currently fund 23 of those public health departments. And then that third component of BOLD is increasing data analysis and timely reporting of it. The legislation calls out specifically CDC's BRFSS, the Behavioral Risk Factor Surveillance System, and it also calls out NHANES, which is the National Health and Nutrition Examination Survey. But I think, this is an audience who gets how all of these pieces relate. And this audience gets how that data is so darn important. So because of data, that's one of the reasons why we've asked our awardees to identify in their projects. So why are they starting with one group, or why are they starting with one priority? But it hopefully is they're using a very data-driven approach for that. So CDC, we like the data. I know I've said it 100 times already in the past couple minutes, but we truly believe in data for action. So I encourage you to look on our website, cdc.gov/aging, and we have a portal that allows you to go through and put in your state. You can put in South Carolina. You can look at various indicators for older adults. Some of them are cognition, some of those are caregiving. You can use the analysis that we have pre-done. You can download data, or you can make a nice PDF of the data or the variables that you're selecting. You also can do this for the nation as well too, or any states that you're interested in. So this group, I know I don't have to spend much time on this, but we know that when we're talking about Alzheimer's disease and other dementias, it's really hard to get good numbers. We can look at claims data. We can extrapolate. There's a variety of different things that we can do, but we know diagnosis. We know that a lot of people never get a diagnosis, or they may not get an accurate diagnosis. So, it's just challenging, and it complicates the lay of the land. Now, I know every condition says that, but ours is complicated. So one of the alternate ways to do that, which is also more on an upstream approach, is through the subjective cognitive decline. So I've alluded to this a little bit about people who say my memory isn't the same as it was, and it's getting worse in the past 12 months. Now, one of the things that we do know about subjective cognitive decline is we know that it can be a precursor for dementia. Many people with SCD do go on to develop dementia, some don't. What it can do for us, SCD, as a population level, is it's really an indicator of future potential needs and burdens within a community. We also know that that being diagnosed early can be important. And it's diagnosed either with a condition or diagnosed that you don't have that condition, because many of the symptoms that you may be experiencing could be treatable. It could be some medications that you're taking together might make you feel groggy or feel like you're in a fog. And there's a variety of different other really good reasons here why it's so important to talk with a provider early when you are starting to experience some of those changes in memory. Okay, so let's talk a little bit about the BRFSS. The BRFSS is a survey that is collated by CDC. It is a state-based surveillance system that currently is telephone-based. It has a landline component, and also it has a cell phone component to it. It is a surveillance system of community dwelling adults age 18 and older, looking at a variety of health conditions, risk factors, utilization, etc. Data is collected in all 50 states, DC, and theoretically 6 US territories, but in some years it can be fewer than 6 territories. Each year there's at least 400,000 interviews completed, and it is an amazing source of state level data. And for many places, it's the only data that is available. So the BRFSS survey is organized by, there's a core survey, and then there are optional modules. So these are the questions and the information that is available on every person who completes the BRFSS. So in other words, to be part of the BRFSS or so South Carolina, all these questions are administered. The other component is there are rotating core topics. This has only been in place for a couple years. So many times you'll hear us talk about, are those even year questions or odd year questions? And really the whole purpose of dividing the survey this way, the even year and odd years, the logic is on these even and odd years, that if those questions are administered annually, we may not see that much change. So if we administer them every 2 years, we might be able to see some change in them or not see change in them, depending on which way you want the phenomena to go. So really the whole key is the states when they are selecting questions for their BRFSS survey. And yes, each state makes the decisions of what questions to include, except for the core. And we'll get to those options in a second. But the point is the state wants to keep their survey as short as possible because they want people to complete the entire survey. Many states like to keep their survey about 20 minutes, and which is pretty short. So it is competitive to get questions on the survey. All right, so here are the optional modules. Now, these have been cognitively tested. These have been presented and approved by the BRFS coordinators in all states and jurisdictions. But then it is up to a state. So if you're on this approved list, it is up to the state to decide which questions they are going to ask in what years. So just because you're on this approved list doesn't mean they will ever ask these questions. But I'm going to talk about today, my program has 2 different modules on the optional modules. So we have the cognitive decline, which is where the subjective cognitive decline comes from. And then we have a caregiving module. The cool thing about that caregiving module is it's not condition specific. So in other words, it's not just for someone who has dementia and is receiving care. It is, so you might be a caregiver for a person who's a little bit younger who may have some type of a cancer. So there is a spot on there where the caregiver indicates what the main reason is that the person is receiving care. So if you're interested in cancer caregiving, this module is for you as well too. Okay. So our cognitive decline module, which is really the focus today, gives us an indication of the prevalence of cognitive decline and also some sort of a glimpse of how it's impacting the person's daily lives. And we also do ask if they have talked with a healthcare provider. So our our cognitive decline module has been administered quite a bit, as you can see, across the US. There are certain states, a couple of them listed here. The purple ones have administered the module every year that it has been available. And let's see, South Carolina, you're doing pretty good too. You're in there several times. So you're with the majority of the states. But for an optional module to have this amount of uptake is absolutely amazing, absolutely amazing. And really that is due to our great partners who work with their states and their state BRFS coordinators to show the need for this data within their state, and also show other advocacy groups within the state how to utilize that data. So in other words, take that data, use it for action, decision making. And that is extremely powerful, because if you're running a survey that has limited space for the number of questions that you can have on it, seeing that that data is being used and seeing that that data is being used to make a difference in people's lives is very, very impactful and very, very meaningful, because nobody likes to collect data that just sits on a server somewhere. Okay, so we also at CDC like to make the data in ways that's interesting, that people can get access to. So we have a variety of different infographics that are on our website. We have state-specific infographics, and we also have them by a variety of groups. Some of those groups are race, ethnicity. Some of those groups are rural. So there's a variety of different stratifications that are available on our website. These are free, they're downloadable. You know, you just click and print and they are yours. And please feel free to share them. Okay, so a couple more things and then I will go. I mentioned with BOLD the National Health and Nutrition Survey. So we do have some questions on the NHANES survey related to cognition. Honestly, this is really cool. And we just got the data and I haven't got to see what's going on with this data yet and what data there is in there for action. But the National Health and Nutrition Survey has two components. It has an in-home interview component. And on that question, we have our subjective cognitive decline on that specific survey. Then the other component of NHANES is in their mobile examination center. So people who come into the mobile examination center, they're having blood drawn, they're providing urine samples. They're getting really a complete physical. I mean, they're getting their eyes checked, their ears checked, their teeth. And honestly, it's more than the complete physical I know that I probably had this year. But the neat thing is, with this, you can get access to a whole gob of different biomarkers. Now, what we put on or included in the mobile examination center is the MOCA, which is a cognitive assessment battery. So there's so many really, really neat analysis that can be done using a cognitive performance measure with some of those biological markers. This was administered in NHANES for 19 and 20. Obviously, 20 was cut very short due to the pandemic. Now, the thing that's the negative about this NHANES data is the way NHANES is administered is it takes 2 years to get a national sample. So they literally start on the East Coast and they work their way to the West Coast during that 2-year cycle. They didn't make it all the way to the West Coast. So this is not going to be a nationally representative sample, but it's going to be a really interesting sample. So they're calling it the pre-pandemic sample. So that is available or will be publicly available very, very soon. And then we are planning on supporting those questions again in the 24-25 cycle of NHANES. Prior to that on NHANES, during the 11-12 and 13-14 cycle, we had a little bit different questions on the survey that you can see listed here. So these are publicly available and can be used by anyone to write papers, do all kinds of analysis with too. So I encourage you please to check them out. Your tax dollars did pay for them. The last thing I'm going to talk about today nationally, so this is getting back into the policy thing, is in 2011, President Obama signed into law the National Alzheimer's Project Act. And in that Project Act, it required that there is a National Advisory Council. And this National Advisory Council has federal representatives, mostly from HHS, and also has non-federal representatives that serve on this council. Part of that legislation is this group must meet quarterly and also annually produce a national plan. So this national plan that you're looking at here is released every year. And 2012 was the first year it was released, and through 2020, that plan included 5 very ambitious goals. So very pleased to say that in 2021, the national plan added a 6th goal. This is huge. This is the first time since the plan was signed into law that there has been a 6th goal added. One of the reasons why we have that 6th goal now is because of data. We know that there are certain things the data shows us that people can do that can help promote a healthy lifestyle that may also reduce their risk of dementia, or it may delay the onset of dementia. So this was a very collaborative activity between CDC, the Alzheimer's Association, Us Against Alzheimer's, as well as about 100 other individuals, federal, non-federal, and other professional organizations. So I know 2021 sounds like really so long ago, but honestly, this was not released until actually after Christmas in 2021. So it's still pretty new. And we are extremely, extremely excited about it and looking at what upstream efforts can be done related to risk factors. So here are the goals, or I'm sorry, the strategies related to that goal. You can see research is important, clinical practice is important. C is one that's near and dear to my heart, which is accelerating public health action. You can see a whole variety, looking at interventions, what can we do? Making sure that we definitely focus on inequities or inequalities and other ways that we can also engage the public to reduce our risk. So with that excitement that we are very, very excited about, I'm going to pause and say, if you do not receive our newsletter, please sign up. And also check out our website, cdc.gov/aging. And I thank you very much for your time.
Thank you so much, Dr. McGuire. All right, and Taylor Wilson, whenever you're ready to share screen.
So hi there, everyone. I actually didn't make as many slides because I am in charge of doing everything that Dr. McGuire just shared with you all. As the Director of Government Affairs, I am the key state Alzheimer's person to go out who has to try and convince the state public health department to apply for BOLD, which South Carolina did get funded for our BOLD plan. We're super excited about that. Then I also am responsible for going and finding friends to partner with us to pay for BRFSS for those questions. So everything that she just shared, I could share those slides and be like, I found somebody to do this. So those 2 times that we've done the cognitive model, I went to Dr. Friedman at the Office for the Study on Aging and begged her. And then I went to the Department on Aging and begged them. And this year, we've actually been able to include it in our BOLD grant, and we got funded for that. So BRFSS caregiver and cognitive model will be done back to back. So we're using our data. But the way that I have to start these conversations starts with do you know that we have the oldest registry in the nation, the oldest Alzheimer's registry in the nation? And you know what that data is telling me? It's telling me that Alzheimer's and all related dementias are a public health problem. It's telling me that we have the 6th highest death rate in America. It's telling me that this is only increasing. We know that we have a state that has a retirement state. We know that we've incentivized people to move here with lower tax rates. And we know that we don't have the infrastructure based on how rural our state is to be able to support any of the need that we have. And I do that with the data from the Alzheimer's registry. I take information and that they are able to distill for me, because everybody knows I don't have doctor in front of my name. And I utilize all of that data to make the story of dementia in South Carolina and how it's affecting South Carolinians every day. And in that process, in these conversations, of course, public health, aging, they all know that this is a problem. But the people who didn't realize it, the people who hold the purse strings, the legislators didn't know. And so this is something that we've done. We've done it once, I believe, and we're going to do it again, is we actually made a decision that we were going to make county-specific fact sheets that were going to tell the story of dementia in an elected official's area. We were going to tell the story of what happens with dementia in their district. And so I'm going to share that with you now so you can see what one looks like. As you can see, this is Abbeville County. I just picked the first one that was in my folder, which was A. And we did these in January 2021, which was the start of a new legislative session. And our legislative sessions go for 2 years. And these were all in a welcome packet. So we have 46 senators and 124 House members. And regardless of kind of like the county, we took what counties they covered, because some House members have pieces of Allendale, pieces of all of these little pieces of Hampton, pieces. We gave them every fact sheet for every county that was in their district, along with a letter that explained that this came from our Alzheimer's registry, which is the oldest. And as you can see here, we included information that I think is very pertinent to starting a conversation. The first is we did a county map. They know where that piece of their county is, where they can see the highest prevalence. We also did the total number of people who were diagnosed based on the registry data and the increase that they had seen since 2000. As you can see for Abbeville, there's a 235% increase. Immediately, as soon as they saw that statistic, the senator and the House members for Abbeville were on the phone with me. What's happening? Why is this happening? They had questions. People that were not calling me before, people who had not necessarily talked about dementia legislation, talked about state agencies putting dementia into a state health plan, improvement plan, all of that, they were on board as soon as they saw this. You can see we have cases by age, cases by race, and also the place of residence. The place of residence is really important because that explains our issues around the infrastructure. If you're seeing a 235% increase and there's no long-term care, there's no home and community-based services, there's no adult day centers, there's no personal attendance, then that's going to be a problem in a community. That's going to see the strain start pushing on the caregivers, and while we start to see poor caregiver health outcomes. I used the place of residence to make the case about how it affects our employment. And we started to work with the South Carolina Department of Employment and Workforce, because we recognize that caregivers, once they're put in a situation, may quit a job. And if they quit that job, the organization loses all of that organizational intelligence, all of that organizational knowledge, and then they have to expound more money to rehire that position, sometimes having to hire 2 people to be able to do this job. So we were able to use these fact sheets for every single county to have conversations with lawmakers and state agencies about why they should be invested in dementia, why they should be invested in the infrastructure, why they needed to be invested in caregivers. And this is something that we are going to do. And I feel like maybe I'm informing Dr. Miller of something that she wasn't aware of yet, but we want to do this for next year because we know that we're in the middle of a midterm election. I've got 25, potentially 30 new elected officials who don't know this is a problem yet. I need to be able to give them these fact sheets so that they can utilize this data appropriately to make them aware that they need to be invested in how we are addressing dementia in South Carolina, the cost of dementia in their communities to their constituents. So, we think that this is all really, really important to educate them, but because I get to work with amazing state agencies, I also get to serve for the Alzheimer's Resource Coordination Council, which is the ARCC, which is at the State Department on Aging. And essentially what that does is the ARCC is charged with finding gaps in services to be able to provide in different communities. Well, we overlay the state with these communities and we find these hot pockets and we're able to go, is there a service there? What services are there? If we've seen that there's an infrastructure issue, have we talked to anybody around that community about what's the barrier to bringing industry there, that specific industry? We're able to have a lot more conversation because now we can see it. And there were some things that popped up for us that we really weren't expecting. We were expecting hot pockets of this kind of dementia activity, this concentration in the coast, all the way up and down the coast. And the truth is, that's not where we found it, even though that's the retirement center. We found it in rural communities. We found it in communities where we're starting to see that there's aging, but there's also other health disparities that are causing issues. We know that there's an increase in stroke risk, there's an increase in dementia risk. We know that body health and brain health are intricately connected. We know that all of those things are going to lead to a higher risk for dementia, poor health outcomes, high blood pressure, diabetes, chronic diseases. All of that is going to lead us to where we are going to have more cases of dementia. And that kind of formed our foundation for our grant to apply for BOLD. And so we were able to show that we needed public health to be a part of this risk reduction, early detection, early diagnosis, because of the health disparities that were in our state and how we needed to educate and bring forth this information. And so I've been really excited about what we've been able to do with the Alzheimer's registry data. I am thinking about ways that we can use it every single day. Really excited that we are trying to, with this newest report, have a press conference to tell all of South Carolina that this report is out here. We've also allowed for, the Alzheimer's Resource Coordination Council gives out grants. So that's one of the resources that we direct grantees to when they're writing their grant is the Alzheimer's registry. It is literally a wealth of information if you use it. And that's really the big thing, is that data can drive you, data can educate, data can get you funds. You just have to be willing to use it and ask for it. And we are blessed to work with the Office for the Study on Aging and have the Alzheimer's registry available to us. South Carolina is truly able to reach its tipping point when it comes to working on dementia policy and dementia programming because of this registry and the information that it gives us. So that's what I wanted to share. I know that I didn't have as many slides, but it's also been crossover week, so I've been at the State House all day. So.
Fantastic. Thank you so much, Taylor. And to all of our panelists for today, thank you, Taylor. I'll go backwards for your real world practical example, something that I really started to jot down when Joe was speaking, but it totally rang true throughout all three of your presentations. You collect the data and then you use it for action, right? So the idea is not just to have data for the sake of data. And Dr. Friedman kind of mentioned that as well, how this was really a full circle opportunity to take what we started learning from our keynote speaker, Dr. Thorpe, all the way to how can we use this information to be relevant in the realm of policy in particular, and community organizations. So thank you all for your work in this area. So let's see, we have a question that started in response to Dr. McGuire's presentation. You mentioned surveys preferably being shorter in order to guarantee a higher rate of completion. Do you have any other survey development tips for those learning how to create surveys and administer them?
Well, that comment was meant that when the states are selecting questions for their BRFSS, their concern is about completion rates. There's a statistic, and maybe Taylor knows this, how many phone calls they have to make to get a completed survey. And it's a lot. It's like 20 or 30 or 50 or something like that.
It's a very high number, and I don't know the exact number because they started the most recent module in the middle of COVID, and I think they had actually more compliance because people were stuck at home. And so I think it kind of skewed it a little bit about how many calls, because people were just bored and they were like, "Please talk to me." So
yeah. So I mean, so in other words, from a BRFS coordinator's point, if they get you on the phone they want you to finish the survey if you start. They don't want you 10 minutes or 20 minutes in to say, I've had enough with you people, and hang up. So they're also very sensitive too about the types of questions that they ask as well. They don't want them to be offensive. I mean, it's really, really interesting. If you look at the BRFSS survey, people will tell you more about their sexual behaviors and attitudes than income. Income has the highest number of missing variables. Because, once again, you're telling the federal government your income. And that would make some assumptions that data systems are linked, which we all know that they're not as linked as well as they should. But no, so the thing is, so in other words, they said, someone put in the chat about scam calls. So federal surveys are exempt from the federal do not call list. But no, it's definitely a concern and an issue. Some national surveys send you postcards to let you know that someone at your household will be selected. And that's how, like, for example, I think it was the National Immunization Survey, they sent a postcard to my house. And when they called, I wasn't randomly selected. My husband was. And he had no clue which kid had what shot when. So he's answering the survey saying, Lisa, when did he have the measles shot? That kind of stuff. But, the information did get into the survey. So you knew it was legit, but there's a variety of different ways to make sure that the surveys are legit. A couple other things I wanted to say. Taylor, if you came knocking on my door and I was a cranky coordinator, I don't know how I could say no to you. Or the same thing with a legislature person. You've got passion, and you really are showing how that data is important and how it's really data tells a story, and it really takes a person.
Looks like Dr. McGuire may be frozen. But Taylor sounds like she has some really amazing things to say about you.
I appreciate that she froze right when it happened. It would have embarrassed me.
Dementia. I'm sorry.
Oh, no, sorry. You froze for a second. And they said, the joke was you were about to say something nice. And I said, I would have been too embarrassed to have somebody of your caliber say something nice to me on a group.
No, don't say that. Don't think of it that way. But I think it's important to, have the faces in mind of the people we're telling those stories about. Because each of those stories, it's talking about hundreds or thousands of people. And I think it's really important for us to all, no matter where we are in our careers, to make sure that we definitely stay grounded. And even, you may not have a family member who has Alzheimer's or dementia or is a caregiver, but my gosh, somebody. It might be somebody at church. It could be your girlfriend. I mean, listen and kind of have those images in your mind as you're moving forward, I think.
I think another thing that I would add to that about telling the story and how data tells the story is that businesses need you to tell that story to them because that's what they go off of. They go off of their spreadsheets and their charts and graphs. So don't be afraid to take some of that data to your county chambers of commerce. Mm-hmm. I did that for a few that had some really big hotspots, and they actually were like, we'll open up our doors to have training here. Is there a way that we can get somebody in here to apply for a grant to be able to do education? What do we need to do? So you can talk to business leaders too, using that data, because that's their workforce. That's the people that they're relying on to make their money. So it's about telling the story to anyone that will listen in a way that it impacts them. It impacts their outcome. And so that's a thing too. Please include the business community, because they need to be a part of this.
Taylor's got this messaging down because
something that you mentioned at the start of your presentation was about the fact that you work with researchers at the university who can make the data more digestible, right? And so I think that if we also honor the perspective that the way that we communicate these data is really important, and value how best can we communicate it so that our important constituents understand it, I think it is also an important piece of this. for sure. So we have a question for Joe regarding AARP. And so the question for you, Joe, is that AARP has such an amazing presence. What is AARP's strategy to reach out to younger family members or caregivers to encourage sharing this type of information that we're chatting about today?
Well, I can tell you, Lucy, one of the things that we're looking at across the board is our brain health efforts here in South Carolina, and how we as a staff can continue to connect brain health, Alzheimer's, our caregiving outreach. We have all of those different aspects. And so that is what we're looking at. What is it that we can do and how can we best deliver that information? And I can tell you, just from having knowledge of the research that is available to us through the registry. I know that Joe Myers from our office manages our Veterans Affairs, but he also serves on the coordinating council that Taylor manages. And so I can slowly begin to see those dots connecting for AARP South Carolina as we continue to share information and resources with our members across the state and their family members. More to come.
Absolutely. And Joe is a great addition. He's actually on the public health subcommittee, which is the brain health connection. And I think what's really interesting is when you're talking to younger people and caregivers, recognizing that there is risk reduction that they can start right now. And that's the conversation that we want to have with those folks, is that, we're starting to learn now that Alzheimer's and other dementias are a continuum. And if they're a continuum, then that means in our 30s and 40s, we need to be making risk reduction choices, which is public health. That's primary public health, intervention. Then we need to have that conversation because caregivers need to take care of their health. And what happens every time, I was a caregiver myself for my lady, loved her more than anything. She raised me. She was my grandmother. But she wouldn't sleep. I called her my Pop-Tart because about 3 a.m. she'd pop out of bed. And it was just like, I'm dying. I'm her primary caregiver. I have to go to work. And, I wasn't taking care of myself. And so I really had to make some effort to change the way I was caregiving, to bring in night people so that they could sit with her so I could sleep. It's about talking to caregivers about their own health and their risk reduction choices that they're making now to try and prevent them falling into that continuum of actual active dementia, that, an Alzheimer's dementia where you can actually see the cognitive decline.
And I go back to that quote, I put it in the chat where you said, Taylor, body health and brain health is intricately connected. Man, I think that's a message that as a provider, as a AARP, as we're developing our messaging and providing the services to the younger caregivers, we begin to make that connection, because so much of what health disparities is about is us also recognizing the need to care for our bodies and the bodies of those in our community.
Right.
And I want to
Bodies and
echo
minds, bodies and minds.
Yeah, and I want to echo what both of you ladies have said. It's key, and that's one of the reasons why I am so excited about this new goal 6.
Yes.
Because if you think about the kinds of behaviors that we talk about keeping our brains healthy, those are the same kind of behaviors that are going to keep your body healthy.
Right.
And so that's why I am so happy the Department of Health and Human Services chose to add promote healthy aging and reduce the risk of dementia. That was a huge, huge step for the Alzheimer's Council to add that in there. So right now we have national movement, national momentum behind this. And I say, man, let's run.
I'm right there
with
with
a marathon, not a sprint, but let's run. And then also, both Taylor and Joe have mentioned the healthy brain, healthy heart kind of things. Also on our website, we do have some messaging. We worked with ASTO, the Association of State and Territorial Health Officials, that has healthy brain, healthy healthy heart, healthy brain, something like that. It's got all those words in there. Those, once again, they're tailorable messages. You can put your own logos on them, take them, use them. We want you to use that information, but it's key. People want to dissect the brain from the body. I mean, come on, how successful are we going to be with that?
Right. The other
Not
thing
at all.
The other thing I would mention, it's so important when we're looking at strategic planning as it comes to state health plans, anything like that, getting in a public health message is so important. So the Alzheimer's Association is currently working, South Carolina chapter is currently working on updating our state plan that's 13, 14 years old now. And we are making a graduated effort to put public health into that plan as many places as we can for primary, secondary, and tertiary actions, because we understand that this is a continuum. It's about how do we incorporate I talk about it all the time, but how do we incorporate childhood education for sandwich generation caregivers so they understand what's happening in this process with grandma and something that's happening with them? How do we bring back into communities a conversation about healthy eating and healthy aging? How do we And it's the continuum. So if you're looking at strategic planning that's going on in your state aging unit, in your state public health unit, make sure the reverse is true, but make sure dementia is mentioned in your public health SHIP plans. And on the flip side, make sure if your aging unit is doing a plan that dementia has public health prevention strategies and early detection, early diagnosis. And you can make that case with the increased numbers that you're seeing in rural communities with poor health outcomes.
Thank you to all of our panelists for joining us. We have reached the end of the time for this session, but we do hope that you'll remain with us for our final session of the day. So thank you again. It's such practical advice for how we can shift from having access to the data, but then integrating it and using it to promote our initiatives and policies. Thank you so much.